Today, today we're going to discuss two long cases in respiratory medicine. And these two cases are very, very important cases. When you will sit for FCPS exam or MD final exam, these type of cases you will get. And we have prepared for you as a dummy examination. Our two presenters will present the case. They will be the examining. And all the attendees are the examiner. Already Dr. Norshaba told you that you should sit with paper and pencil or pen, and you will note the important things about history, physical examination, differential diagnosis, and also note important things from crossing. And if you get all the answers from the crossing, it's okay. Or if you want to ask anything, you can ask in chat box. We'll try to reply. We'll try to give you answer. Or if we can't give you proper answer, we'll give you proper reference. So our first presenter, Dr. Sharmin Sultana, will present your case. Dr. Sharmin Sultana, please start your case.
You have to unmute yourself.
Unmute kore na.
Assalamu alaikum. Can I hear you?
Clear.
Thank you, sir, for giving me the opportunity to present my case in this academic session. I'm Dr. Sharmin Sultana, going to present my case. Mr. X, 62-year-old male Muslim, married, retired banker, hailing from Munshiganj, got himself admitted in our department on 2nd September 2021 with the complaints of gradual swelling of face, upper part of chest, and right upper limb for 5 months, hoarseness of voice for 4 months, cough for 2 weeks. Patient stated that he was reasonably well 5 months back. Since then, he developed gradual swelling of his face, upper part of the chest, and right upper limb. Swelling gradually increased over time and became more marked for last 1 month. He had no associated history of pain, skin change, warmth, trauma, impaired sensation in the right upper limb. He also noticed change in voice in the form of hoarseness of voice for last 4 months, but not associated history of difficulty in swallowing, overuse of voice, sore throat, exposure to fire or smoke. Patient also mentioned cough for 2 weeks, which was usually dry with occasional scanty whitish mucoid sputum expectoration present throughout the day and night, but no history of coughing up of blood or foul smelling of sputum. On further questioning, he mentioned history of dry cough and shortness of breath since childhood. Shortness of breath was episodic, mainly during winter season. Between this episode, he remained asymptomatic. He also experienced wheezing and chest tightness during exacerbation, sometimes more marked at night and aggravated by cold, dust, and fume exposure. No relation with any meal, posture change, or heartburn. He had also history of occasional runny nose and sneezing, but no history of chest pain, difficulty in lying flat, paroxysmal nocturnal dyspnea, swelling of legs or abdomen. He gave history of loss of appetite and 2 kg weight loss during this period of illness, but denied any history of fever, night sweat, history of previous tuberculosis or close contact with smear positive pulmonary tuberculosis patient, any nausea, vomiting, feeling of lump in the body or any joint pain, yellow coloration of skin, eye, skin rash, any pigmentation, itching, frequency of micturition, or any abdominal pain, muscle weakness, or wasting. With these complaints, he visited local physicians several times with no help. Patient is diabetic, for last 8 years, diagnosed incidentally and was treated with oral anti-diabetic medication initially. But for the last 6 months, his glycemic status is poorly controlled. That's why insulin was started. Now he's having optimum glycemic control. During this period of time, he had no history of hypoglycemic or hyperglycemic emergency or any history of headache, blurring of vision, convulsion, unconsciousness, tingling, numbness, any sexual dysfunction, or history suggestive of any other diabetic complication. Patient also his known case of hypothyroidism for last 8 years, diagnosed on the basis of classical history and laboratory investigation, and he's taking levothyroxine supplement irregularly. Patient is hypertensive for last 7 years. He's on medication with optimum control, no history suggestive of any hypertensive complication. He had constipation and bladder habit was normal. Regarding past illness, he had no history of childhood pneumonia, whooping cough, or measles, no other significant history of past illness or any surgery. He received several medications during this period of illness, including tablet metformin, short-acting insulin thrice daily subcutaneously, tablet amlodipine once daily, tablet levothyroxine, some cough syrup, the name of which he couldn't mention, but also received some inhaled bronchodilator, tablet montelukast, but no history of taking any over-the-counter or herbal remedies. He's ex-smoker about 5-pack year. He used to take betel nut, no history of recreational drug abuse or alcoholism, no history of any unsafe sexual exposure. He is blessed with 3 daughters and 1 son. All of his family members are enjoying good health. His father died of stroke at the age of 80, mother suffering from asthma, but none of family member has similar illness like diabetes or hypertension. Patient is from middle socioeconomic status. He has access to proper sanitation and pure drinking water. He was given BCG vaccination at birth, no history of adult vaccination and COVID vaccination. He was not known to be allergic to any food or medication and no significant travel history. Regarding physical examination, on general examination, patient's face edematous, plethoric, periorbital swelling present. There was drooping of right eyelid with enophthalmos, congested conjunctiva, and right side of the face was dry. Right upper limb swollen with visible encouraged vein. Average body build, cooperative patient, decubitus on choice, no anemia, jaundice, cyanosis, dehydration, edema, but digital clubbing present. No leukocytia, koilonychia. Pulse was 62 beats per minute, not regular in rate, rhythm, and volume. Blood pressure was 110/70 millimeter of mercury with no postural drop. Respiratory rate gland not enlarged, lymph node are not palpable, and JVP raised, which was non-pulsatile. Saturation of oxygen 96% in room air. Skin condition overall dry, rough, and thick palm and sole. No bony tenderness, gynecomastia absent, bedside urine test negative for protein and sugar, body hair distribution was normal. Regarding systemic examination, respiratory system examination on inspection, chest was swollen with visible inverse tortuous vein in the upper part. Direction of blood flow was above downwards. No intercostal indrawing, supraclavicular excavations, prominent accessory muscle of respiration, and no scar mark. Shape of the chest normal, respiratory rate was 18 breaths per minute, movement bilaterally symmetrical. Trachea was central in position, apex beat in left, 5th intercostal space just medial to mid-clavicular line, normal in character, chest expansion about 5 centimeter, vocal frame it was normal, no rib tenderness. Percussion note resonant all over the chest. Upper border of liver dullness was in right 5th intercostal space along the right mid-clavicular line. Area of cardiac dullness was in normal position, and breath sound was vesicular with prolonged expiration along the all over the lung field with few rhonchi present. Vocal resonance was normal. Regarding other system, precordium examination reveals normal. Neurological examination, normal higher psychic and function and speech. Examination of eye reveals meiosis, partial ptosis, and enophthalmos on the right side, and there was also right-sided facial anhidrosis. Cranial nerve examination normal, except there is a evidence of multiple dot hemorrhage present bilaterally with 1 blood hemorrhage at 3 o'clock position in the left eye in fundoscopic examination. and other parts of the nervous system examination normal except the evidence of delayed relaxation of ankle jerk. Other systemic examination, including musculoskeletal system examination, parabdominal examination, reveals nothing abnormality. So with this history and examination, my provisional diagnosis is superior vena cava obstruction with right-sided Horner syndrome due to bronchial carcinoma, with type 2 diabetes mellitus, with diabetic retinopathy, with hypertension, with hypothyroidism, with asthma, with allergic rhinitis. This is all about my presentation.
Thank you, Dr. Sharmin. Now, Dr. Aminul will ask you some questions. Dr. Aminul, please.
Sir, you unmute.
Thank you, Dr. Sharmin, for your detailed presentation. In real life, when you are in examination hall, just within 30-minute time, you will have to gather. I am talking to all, not to Sharmin. Within 30-minute time, you will have to gather all the information from history by talking with the patient and examining the patient. And present to the you will have to be ready to present to the examiners within that stipulated time, within that 30-minute time. So see how much dedication, how much consistent practice you are needed. Dr. Sharmin, you have presented the case nicely. You mentioned the patient is rhonchi and vesicular with prolonged expiration, right? But the patient has no breathlessness. You did not mention that there is no, you did not mention breathlessness. Was the patient breathless, or he was without any respiratory distress?
Yes, sir. Thank you, sir, for your question. Patient has no breathlessness during examination. But patient didn't give any history of breathlessness, but during examination, I found that patient has a vesicular expiration with a few rhonchi present all over the lung field.
Yes, rhonchi or prolonged expiration is not the marker of respiratory distress, but usually these are present with respiratory distress. But if you didn't find, that's okay. With rhonchi, a patient may remain breathless. So from your history, the patient seems has hypothyroidism, active hypothyroidism, despite having thyroxine supplement. Probably he's in under treatment.
Yes,
but
sir.
you didn't ask the patient about cold intolerance. Do you think that as the patient has constipation, the patient has delayed relaxation of ankle jerk, and patient is on thyroxine supplement, you should ask the patient about other symptom of hypothyroidism like a cold intolerance?
Yes, sir. Patient, I have asked the patient, and patient also mentioned that during diagnosis, patient has this type of classical symptom present, like weight gain, cold intolerance, constipation that I mentioned in my presenting illness. During diagnosis, patient has this classical symptom.
But from in history, we get most of the information, but cold intolerance is a very significant symptom of hypothyroidism. You did not mention it. We should mention to know, to see whether his thyroid supplement is adequate in this point of time. Okay, the patient has, your diagnosis is superior vena cava obstruction. Superior vena cava obstruction due to malignancy. You have mentioned some local feature of any of malignancy, say cough. This is a local feature, and there is no hemoptysis. You have mentioned some feature of metastasis like jaundice, You have mentioned several feature of compression, say superior vena cava compression, recurrent laryngeal nerve compression, hoarseness of voice, sympathetic trunk compression like Horner syndrome. Have you mentioned? Should you mention any other feature of compression in this case in surrounding area compression? That means you have got feature of superior vena cava obstruction. You have got feature of recurrent laryngeal nerve compression. You have got feature of sympathetic trunk obstruction manifested by Horner syndrome. Any other symptom patient may develop in this situation by compression of any pathology within the thoracic cavity, which you have not mentioned in your history?
Sir, in case of superior vena cava obstruction malignancy, several compressive feature patient may develop. I was searching that patient has any history of stridor due to tracheal compression, any swallowing difficulty due to esophagus compression.
That is the point. That means
Yes, sir.
dysphagia.
Dysphagia, sir, I have already mentioned in my history, patient has no difficulty in swallowing.
Sorry, there in that case I have missed that. So your diagnosis is bronchial carcinoma. So why not other pathology that may cause superior vena cava obstruction? Which points go in favor of bronchial carcinoma in your case?
Yes, sir. Malignancy is my first differential diagnosis that causes the superior vena cava obstruction, and other differentials also is my consideration, as my patient is elder, male patient, smoker, and also patient history of weight loss, and on examination, general examination, patient has digital clubbing and evidence of superior vena cava obstruction. That's why I consider the bronchial carcinoma is my first differential diagnosis, and I have some other differential diagnosis also, like lymphoma may cause the superior vena cava obstruction. Sometimes retroesternal goiter can cause the superior vena cava obstruction. Some other rare pathology can cause superior vena cava obstruction, like if there is aneurysm of the aorta or its branches can causes the compression of the superior vena cava obstruction compression, and also sometimes the thrombosis within the vena cava itself causes the superior vena cava obstruction.
Why it is not lymphoma?
Lymphoma is my differential diagnosis, as the patient has no classical history of lymphoma, like patient has no evidence of history of fever, any history of lump in the body, or on examination I didn't get any lymphadenopathy, any skin scar mark, or any organomegaly or any organ involvement. That's why I consider it's my second differential diagnosis.
Another point is you have got clubbing. Usually bronchial carcinoma causes clubbing and lymphoma does not cause clubbing unless it is familiar.
Yes, sir.
Say you have got upper border of liver dullness in 5th space. In your case, if you get it at 3rd space, that means hemidiaphragm is elevated. How can it be explained?
Yes, sir. It can be possible if the phrenic nerve involvement or collapse of the lung. In that case, hemidiaphragm is elevated.
Number 1, collapse. Number 2,
if phrenic nerve involvement can causes the elevation of the diaphragm.
Without elevation of diaphragm, can you get dull percussion note in lung base in that case, in this case?
Sorry, sir, question.
And without say the diaphragm is not elevated. Your previous answers was based on elevated diaphragm, and you are getting dull percussion note. So that in a case of bronchial carcinoma, you are getting dull lung base. What are the possibilities? Other than involvement of phrenic nerve, other than collapse, what other causes may cause? dull percussion note at lung base. So,
Sir, what are the
what are the causes of dull percussion note at lower lung field?
yes, sir. Some other cause can cause the dull percussion in the lower lung field if a patient has a pleural effusion on that side,
Very good.
or pleural thickening, or there is any musculation in the lower lobe of the lung, or collapse, and phrenic nerve involvement also one of the possibility, and subdiaphragmatic pleural effusion, or any sometimes hepatomegaly pushed up the diaphragm, or any liver abscess sometimes cause the dull percussion in the right side of the chest.
Yes, thank you. So in this particular case, most commonly a collapse, pleural effusion, and involvement of phrenic nerve and metastasis to the liver. Thank you. Nice answer. So the patient has rhonchi, has vesicular with prolonged expiration. Did you notice any inhaler or nebulizer machine in the side of the patient, the table of the patient, or any sputum pot under the bed? Have you mentioned in your history?
Yes, sir. Yes, sir. I have mentioned in my treatment history, patient received some inhaled bronchodilator and also Montelukast, and also I noticed in the patient bedside, patient used to take inhaler.
Patient used takes inhaler, and you have seen by your eyes directly that the inhalers are present at the table of the patient.
Yes, sir.
You have mentioned headache, no headache related to diabetes. Is there any importance of mention headache related to bronchial carcinoma in this case? When we present a case of bronchial carcinoma, we point out some points: local feature, cough, hemoptysis, compression, we have already mentioned, and metastasis. In metastasis, two important site is vital: liver and brain. In liver, you have mentioned there is no jaundice, and you add no headache or any neurological complication in history. Altered consciousness, headache, considering to exclude metastasis to brain. Say you are asked to examine the patient focused to your case, not as a whole. You have nicely mentioned the general examination points and all the points. Just if you are asked the general examination related to your case, that means general examination related to related to superior vena cava obstruction. What are that examination points?
Superior vena cava obstruction, in that case, I expecting in general examination that I already mentioned the patient's appearance, the face, there is a edematous, erythematous face, periorbital edema, congested conjunctiva, and the swollen neck and upper part of the chest and right upper limb, swollen, erythematous, and also very important is the direct tortuous vein, that direction that should be upward to downwards. And also I want to look for the clubbing and any lymphadenopathy in general examination, and also thyroid gland and JBP is also important. In that case, non-pulsatile raised JBP I expect.
Okay. Thank you, Dr. Sharmin Sultana. Now I'm requesting Professor Mohiuddin, sir.
Thank you, Dr. Sharmin, for presenting your case. Now tell me, how are you going to investigate your case?
Sir, for investigation, I want to consider some routine investigation and some specific investigation to establish my diagnosis. Routine investigation consider the complete blood count. There may be low hemoglobin in case of bronchial carcinoma or maybe due to hypothyroidism, and also the chest X-ray posterior view where expecting there is any superior mediastinal widening or any right hilar mass or any lymphadenopathy or any lung opacity, and also some other routine investigation including the renal function test, blood sugar profile to see the glycemic status of the patient, and also thyroid function test to see the thyroid status, and ECG and ultrasonography of whole abdomen to see any intra-abdominal lymphadenopathy or any organ involvement. Investigation, I want to consider here the CT scan of chest with contrast to see the level of the lesion of superior vena cava and severity, and any lymphadenopathy or mediastinal.
হ্যাং হয়ে গেল তো, শোনা যাচ্ছে না।
I'm going to disconnect from this, sir.
কল আসছে মনে হয় আর কি, মোবাইলে ধরে তো এই সমস্যা হলো এটা, আবার কানেক্ট।
আমার মনে হচ্ছে কম্পিউটার থেকে, কারণ স্ক্রিন শেয়ার দিয়েছিল তো স্যার, কম্পিউটার থেকে তোমাকে আসবে। আপু আনমিউট করতে হবে আপু।
হ্যাঁ, can you
বলো,
hear me?
ডিসকানেক্ট হয়ে গেছিলে তুমি?
আচ্ছা আচ্ছা। Specific investigation, CT scan of chest with contrast to see the lesion, the superior vena cava obstruct site of the lesion and severity, any lymphadenopathy or any mediastinal mass or any lung lesion that can cause the superior vena cava obstruction. Sometimes the thrombosis in the superior vena cava, it also visible in CT chest with contrast.
Which type of CT scan you will prefer, HRCT or CT with contrast?
CT scan, CT with contrast.
Why?
Because the in this case, my searching point is the mediastinal structure, any mediastinal mass or lymphadenopathy. That's why I choose the CT chest with contrast, because in case of HRCT scan of chest, we usually see the parenchymal structure, lung lesion. We want to find out.
How you will do the tissue diagnosis of this case? You have told this is bronchogenic superior vena cava to bronchogenic carcinoma. How will you make your tissue diagnosis?
Tissue diagnosis, in that case, I want to consider the it depends upon the site of the lesion, fiber optic bronchoscopy with biopsy.
Suppose you found no endobronchial lesion.
In that case, if there is any lymph node biopsy is another option.
Okay. What are the possibilities? What will be the expecting type of your tumor? What type of tumor you are expecting here?
Sir,
yeah.
Yes, sir. Expecting it. It may be the small cell carcinoma. May cause the superior vena cava obstruction. This is the most common cause.
Most common. Okay. If it is a small cell carcinoma presenting with superior vena cava obstruction, how are you going to treat this case?
Sir, for my case, the treatment is a multidisciplinary approach. First of all, I want to educate my patient and counseling the patient regarding his illness, and also the patient attendance regarding the patient condition, and also some symptomatic supportive treatment and specific treatment. Symptomatic treatment, I want to consider the diuretics, steroid for my patient, and also some anti-diabetic medication treatment for the comorbidity, anti-diabetic medication for diabetes control, anti-hypertensive medication, levothyroxine for thyroid hypothyroidism, and also treatment of asthma and allergic rhinitis condition, and also specific treatment depend on the cause. After establishing the specific cause, then I want to go for a specific treatment, and also consultation with other department like oncology department after confirmation of my diagnosis, and regular monitoring and follow-up of my patient.
You have already told that your diagnosis is small cell carcinoma. How are you going to treat this case?
Sir, in that case, I want to consider the chemotherapy followed by palliative radiotherapy is the treatment option.
This is the case of non-small cell carcinoma. What next step will do? You have diagnosed this is a case of superior vena cava syndrome. You have diagnosed this is a case of non-small cell carcinoma. What will be your next step?
Sir, if it is due to the non-small cell carcinoma, in that case, it is depend upon the staging of the malignancy. I expect
if you
this
want
is
to do any other investigation for staging, you can do one investigation if the facility is available. Tell me one investigation for staging. If the patient party can afford, if the facilities can available, we just direct you go for this and we make this staging. What is the investigation?
the PET scan of whole body.
Not PET scan, PET CT.
PET
PET
CT.
scan,
Sir.
PET scan is a separate thing, CT is a separate thing.
PET
PET
CT,
scan
sir.
is superimposed on the CT, and these both combines with PET CT.
PET CT.
By doing
Yes.
PET CT, we can do staging. If there is brain metastasis, if there is abdominal metastasis, it will be what stage?
Sir, stage 4.
Stage 4A or B?
B, sir, abdominal metastasis.
Stage 4B. Good. If this is stage 4B case, what will be your management plan?
In case of stage 4B, sir, palliative treatment option is the management plan for
Do
this.
you want to give any emergency radiotherapy to this superior vena cava obstruction patient
Yes, sir.
for any tissue diagnosis?
If patient is symptomatic, patient has severe pain, in that case, emergency radiotherapy is the treatment option to relieve symptom.
Okay. So what will be the prognosis of your case if this is small cell carcinoma?
Sir, malignancy prognosis is poor, and in case of small cell carcinoma, as it is early metastasis occur, in that case, the prognosis is very poor. Average survival is less than 1 year. If in case of if patient with treatment, without treatment, it is near about 3 months.
Okay, thank you, Dr. Sharmin. Our first case is over. If you have any question, you can write in the chat box. We'll discuss it afterwards. Now, our next presenter, Dr. Sharmin Afroz. You please start your case.
Thank you, sir.
Am I audible?
Yeah, আরেকটু জোরে বলো, শোনা যাচ্ছে?
আর এখন শোনা যাচ্ছে?
হ্যাঁ, শোনা যাচ্ছে।
হ্যালো, শোনা যাচ্ছে স্যার এখন ক্লিয়ার?
শোনা যাচ্ছে।
Assalamu alaikum. I am Dr. Sharmin Afroz and I am going to present my case. My patient, Mr. X, 65-year-old Muslim married man who worked as a businessman hailing from Kumilla, got admitted on 4th July 2021 with the complaints of progressive shortness of breath for 8 months, dry cough for same duration. According to the statement of the patient, he was reasonably well 8 months back. Since then, he developed shortness of breath, which is gradually progressive over time. Initially, he felt breathlessness only during severe exertion and MMRC grade was 0. But for last 2 months, he is having difficulty with normal day-to-day activities like washing, going to toilet, etc. And MMRC grade is now 4. There is no history of increased breathlessness while lying flat, no history suggestive of paroxysmal nocturnal dyspnea, increased awareness of heartbeat, chest pain, swelling in the legs or abdomen. Patient also mentioned cough for the same duration, which is irritating, mostly dry with occasional scanty whitish mucoid expectoration, persistent throughout the day and night, no history of coughing up blood or foul smelling sputum. There is no diurnal or seasonal variation of the cough, not aggravated by cold, dust, and fume exposure, no relation with meal or posture change, no heartburn, no history of wheezing, allergy, increased sneezing, nasal blockage, or runny nose, no history of tuberculosis or exposure to smear-positive tuberculosis patient, no history of organic or inorganic dust exposure like pet bird, silica, coal, etc. For cough and breathlessness, he took some medicines and cough syrup from local physicians with no help, the name of which he could not mention. Patient also has history of multiple joint pain and swelling, symmetrically involving small joints of both hands and feet for 7 years, no involvement of large joints. Initially, pain was progressively increasing, moderate in intensity, more at night, associated with morning stiffness that persisted for about 2 hours and relieved by activity and sometimes with some painkillers. There was no radiation of the pain. He also had low-grade fever, malaise, anorexia, and weight loss during initial period of the illness. He didn't give any history of back pain, passage of loose stools, skin rash, nodules, skin tightening, oral ulcer, genital ulcer, hair loss, pain or redness in the eyes, difficulty in swallowing, muscle pain or weakness, convulsion, unconsciousness, tingling, numbness or any sensation problem, weakness in any body parts, passage of dark or frothy urine, burning sensation during micturition, pain or color change of fingers on exposure to cold. With this complaints, he visited outpatient department of a tertiary care hospital 6 years back and was treated with some medications and painkillers. He could not mention the name of the disease. Since then, he is taking tablet methotrexate once weekly with partial resolution of joint symptoms. He is non-diabetic, normotensive. His bowel and bladder habit is normal. He has no history of childhood pneumonia, whooping cough, or measles. No other significant history of past illness. No history of hospitalization or any surgery. Patient is taking tablet methotrexate once weekly for 6 years. He could not mention the strain. He occasionally takes painkillers and some cough syrups from local pharmacy, could not mention the name, and no history of taking any over-the-counter or herbal remedies. Patient is ex-smoker with 15 pack-year smoking history. He has no history of taking betel nuts, recreational drugs, or alcohol. No history of unsafe sexual exposure. He is blessed with 2 daughters and 1 son, and all of his family members and siblings are enjoying good health. No history of familial similar kind of illness. He is a businessman with no history of any other occupation. Patient is from medial socioeconomic status. He has access to proper sanitation and pure arsenic-free drinking water. He was given BCG vaccination at birth. No history of COVID-19 vaccination or other adult vaccination. He was not known to be allergic to any food or medication, and he has no significant travel history. On general examination, patient appeared anxious looking, body build was average, he was cooperative, decubitus on choice, anemia, jaundice was absent, cyanosis, dehydration, edema, and clubbing, edema was absent. There was digital clubbing and leukonychia absent, polyonychia absent, pulse 92 beats per minute, regular in rate, rhythm, and volume. Blood pressure was 110 by 70 millimeter of mercury with no postural drop. Respiratory rate was 20 breaths per minute, temperature 98 degree Fahrenheit, thyroid gland not enlarged, lymph node not palpable, JVP not raised. Oxygen saturation at rest was 96%, but on 2 minutes walking, saturation drops to 90%. Skin condition was normal. There was no bony tenderness, gynecomastia absent, bedside urine test was negative for protein and sugar, body hair distribution was normal. There was no flapping tremor or palmar erythema. There are some bony deformity and mild swelling in his hands and toes with no redness. On respiratory system examination, shape of the chest was normal. Respiratory rate 20 breaths per minute. Chest movement was bilaterally symmetrically reduced. There was no engrossed vessels, scar mark, prominent accessory muscle of respiration, intercostal indrawing, supraclavicular or suprasternal recession, or no visible impulse. Trachea was centrally placed and apex beat was in left fifth intercostal space, just medial to the midclavicular line. 9 cm left from left sternal border, normal in character. Chest expansion is 4 cm, vocal primitus normal, and there was no rib tenderness. Percussion note was resonant all over the chest. Upper border of the liver dullness was in right fourth intercostal space. Area of cardiac dullness was in normal position. On auscultation, his breath sound was vesicular. There was bilateral basal fine and inspiratory decrepitations present along the dorsal scapular line and mid-axillary line, which was unaltered by cuff. Vocal resonance was normal. On musculoskeletal system examination, his examination of the hands reveals there is swan neck deformity in left ring finger, ulnar deviation of the left hand, and there is also flexion deformity of finger on left hand. There is mild swelling of proximal interphalangeal joints of both hands. There is wasting of thinner and hypothenar muscles with dorsal guttering in both hands. No atrophy, ulcer, gangrene, rash, or nodule was seen. There was mild tenderness in proximal interphalangeal joints. Temperature was normal, and movement was slightly restricted with mild functional impairment. On examination of feet, there was lateral deviation with dorsal subluxation of toes, plantar subluxation of metatarsal heads, hallux valgus deformity bilaterally, and feet are flat. There was no tenderness or warmth. Movement was slightly restricted, and rest of the musculoskeletal system revealed no abnormality. Other systemic examination also revealed no abnormality. So from history and clinical examination, my provisional diagnosis is rheumatoid arthritis with interstitial lung disease. This was my case. Thank you.
Okay, Dr. Aminul will ask you some question. Dr. Aminul, please.
Thank you, sir. Thank you, Dr. Sharmina Afroz. The occupation of your patient is business. Which type of business?
Patient has two shops. He is not directly involved. He has some employees and he works through the employers. And this is a shari shop.
Shari shopping. So do you think there is any importance to mention the type of business in respiratory disease, particularly in your case like ILD?
Yes, sir. I have separately mentioned that patient has no history of any organic or inorganic dust exposure. So I have covered later.
The patient may have business with jute. The patient may have business with pigeon or rice that may cause interstitial lung disease.
Yes, sir. I have mentioned it in my history. He doesn't have this kind of exposure history.
One good thing is you have mentioned that no other occupation before or after his current occupation. That means lifelong occupation is to be taken when we are dealing with such case like ILD. So you have mentioned the loose stool, back pain, visual disturbance. What are the importance in this case?
I have mentioned loose stool to explain the enteropathic arthritis and back pain to exclude the seronegative arthritis. I wanted to exclude the other form of arthritis. And in case of rheumatoid arthritis and also other form of arthritis, there may be eye involvement in different forms like scleritis, episcleritis, keratoconjunctivitis sicca. So for these reasons, I have given the eye history.
That means to construct a history, we have to ask the common, the current problems, among the complications of the problem, and any association of the problem. All should be included in a history. And cause of the problem, cause of the disease, cause, disease, complication, association, all should be asked and should be amalgamated in a construction of history. You did not mention any past history of tuberculosis, perhaps, and also you.
I have mentioned, sir. I have mentioned that patient doesn't have any history of tuberculosis and also no history of exposure to any smear-positive pulmonary tuberculosis patient.
You have mentioned. Have you mentioned any history of childhood asthma? And do you think this is important?
Yes, sir. I mentioned about that patient didn't have any history of episodic shortness of breath or wheezing any time period in his life. Though I didn't use the word childhood asthma, but I said symptomatically.
You have mentioned childhood infection, measles, whooping cough. Definitely, that should be mentioned because that may cause bronchiectasis later on, and which may lead to finding of bilateral basal crepitations, as you have thought. So that is a different type of crepes. But you should mention also a childhood asthma patient may develop shortness of breath in later life. Late onset asthma is more common, the patients who have childhood asthma. And patients usually can express that I had asthma in my childhood, or I had respiratory distress in my childhood. That must be mentioned in a past illness and in respiratory history. You have mentioned general examinations thoroughly. If I ask you general examination in the hand related to this case, what are the points?
In this case, I will look for in the hands. At first, I will see the inspection. I will see if there is any pallor, there may be anemia, and I will see if there is cyanosis, it may be evident, and also the pulse volume. If there is associated respiratory failure with carbon dioxide retention, there may be warm bounding pulse, and patient is smoker, nicotine staining may be present in the hand. And also with connective tissue disease related, there may be so many changes, like there is already the patient have joint deformity and muscle wasting. And other than this, I may also found skin tightening for scleroderma. And for other connective tissue diseases or vasculitis, there may be gangrene, there may be ulceration, there may be pulp atrophy, and there may be rheumatoid nodule. And all these things I will look for. And also in psoriatic arthritis, there may be nail changes.
These are the general examination in the hand.
And also clubbing, most importantly, there may be clubbing, and this patient has clubbing.
Clubbing is most important.
Now, we also use pulse oximeter for general examination. So in hand, I will also check the oxygen saturation of the patient.
The nicotine stain will indicate what? In the hand.
Stain will indicate that patient is a smoker, and in case of RA-ILD, there is a relationship with smoking, and smoker patient has more chance to develop RA-ILD.
Nicotine smoker, more appropriately heavy smoker, and it's just a light smoker, you will not get stain. That when there is stain, that indicates a heavy smoker, no matter the peculiar the patient discloses to you. You have not mentioned joint pain in chief complaint. Why? I am not telling that you are wrong. What's your justification that you have kept joint pain in history of present illness, but not in chief complaint?
And right now, patient presented with only the complaints of shortness of breath and cough, and patient is having this joint pain for last 7 years. And it is partially controlled with some painkillers and methotrexate. So right now, patient came with 2 symptoms. That's why I put cough and shortness of breath in the chest complaint. Patient is right now came for joint pain.
Okay, that means we will mention the problems in chief complaint for which patient seek medical help or admission in this moment, current moment. Maybe the joint pain will be the chief complaint some other day. In that period, maybe shortness of breath or cough will be in the present illness, history of present illness. It depends on a patient's situation. Or maybe both, all the three, shortness of breath, cough, joint pain will be in the chief complaint if all are giving pain in this point of time. So you have mentioned methotrexate, that means your differential diagnosis, the drug induced. Okay. Have you asked any other drugs that may cause pulmonary fibrosis? And you have not mentioned in your history. We have seen only methotrexate he is having. What important drugs are not patient having that may cause these features, say ILD-like features. ILD-like features, not that means just ILD, drug-induced ILD. What are those drugs?
The patient, but patient is taking only methotrexate, and other than methotrexate, patient could have taken penicillamide or some other drugs like gold. Otherwise, some other medications like antibiotics, nitrofurantoin, some chemotherapeutic medications like bleomycin, busulfan. These medications can cause drug-induced fibrosis.
As drug-induced ILD is a differential diagnosis, you could mention the name of this drug as important negative history, but you did not. You have mentioned that rheumatoid arthritis with ILD. And you have written RA-ILD. Are both same, RA-ILD and rheumatoid arthritis with ILD?
Sir, I have diagnosed, my provisional diagnosis is patient is having rheumatoid arthritis with interstitial lung disease.
Rheumatoid arthritis with interstitial lung disease.
Yes, sir. And this is in the form of RA-ILD. This is now established. So I have put this way.
This is dual pathology, or there is interlink between the two?
There is interlink due to this is the similar disease process, rheumatoid arthritis now affecting the lungs.
Which type of ILD you are thinking of in this patient?
In rheumatoid arthritis, there may be UIP pattern or there may be NSIP pattern, but UIP pattern is slightly more common, and there may be also mixed pattern, mixed UIP and NSIP pattern. And other than this, some other form like organizing pneumonia may be also seen, and some patients who are heavy smoker, CPAP, combined pulmonary emphysema, and fibrosis is also sometimes found associated with rheumatoid arthritis.
What's the age of your patient?
65 years.
65. So a 65-year male patient, which is more likely?
More likely, this may be a case of UIP, histological
UIP
pattern or
pattern.
radiological pattern, most likely UIP.
So why not this is IPF?
We can say IPF when there is no recognizable cause, but in this patient, we have found the recognizable cause, that is rheumatoid arthritis. So that's why I'm saying that is RA-ILD. And also
to find out a recognizable cause in case of ILD, what other questions you should ask or you have asked?
Sir, questions. One of the first thing is that I have to exclude the connective tissue diseases, which I have done, and other than this, maybe due to different dust exposure, like organic dust or inorganic dust. If it is due to organic dust, it may be cause hypersensitivity pneumonitis, and later it can develop fibrosis if not adequately treated. And from inorganic dust, patient can develop pneumoconiosis. And other than this, patient's occupational history is also relevant to this. And also, other than these patients, some other history I have taken that related to, and there is in connective tissue disease, there are also several varieties. And to exclude other varieties from RA, I have to also ask some other questions. And also smoking history is very important. Some patients, smokers have some kind of disease, and non-smokers have some other kind of ILDs. And gender is also important. Male and females have some different kinds of ILDs.
You have mentioned patient has no organic dust exposure. Can it be explained more to know that the patient has no organic dust exposure? What questions you have asked?
I have asked about any pet bird or any pet animal in the house, or patients having, he lives in the village, if there is any exposure to the paddy or any grain during the time of the initiation of the symptoms. And if there is patient take any form of exposure to these kind of things before development of the symptoms. But patient didn't give any history of any kind of exposure during initiation of the symptom.
Which bird is most significant to develop organic dust exposure related disease, say hypersensitive pneumonitis?
The pigeon is very common, and we sometimes find this kind of patients in our department.
To know that the patient has no inorganic dust exposure, what questions you have asked?
I have asked the occupation history first. did the patient have any other occupation before this, and which business he is actually doing, and also from surroundings, did he have any history of exposure to any silica or other form of mineral dust, silica, coal, nickel.
What's the upper border of liver dullness level? In your
It was
patient
in the
case?
fourth intercostal space.
Is it in normal position?
It is slightly elevated due to patient have fibrosis, so the lung has shrunken.
Okay, thank you. Thank you. Professor Mohiuddin Ahmed, sir.
Thank you, Dr. Sharmin, for your presentation. Now I will ask you some questions. So, number one, how will you going to investigate the case?
Sir, I will do some routine investigations and some specific investigations and some investigations for treatment and treatment purpose. As routine investigation, I will do complete blood count, ESR, CRP. Raised ESR and CRP will support my diagnosis. I will do chest X-ray. If there is a reticulonodular shadow, mostly involving the lower or mid zones, it will support my diagnosis. And I will also do liver function test, renal function test to see the baseline, and also RBS and also urine routine microscopic examination. As the patient have joints involvements in the hands and legs, I will do X-ray of the hands and legs to see if there is marginal erosion and joint deformity and swelling and also osteopenia. This will support my diagnosis of rheumatoid arthritis. And also to confirm my diagnosis, I will do the HRCT of the chest. And if I find there is bilateral, subpleural, reticulonodular shadow, mostly in the basal areas, along with honeycombing and traction bronchiectasis, that will support my diagnosis. And I will also do spirometry with DLCO. If I find restrictive defect with reduced DLCO, that will support my diagnosis. And I will also do serum autoantibody profile, and positive rheumatoid factor and anti-CCP antibody will support my diagnosis. And for treatment purpose, I will do 6-minute walk test. And if there is significant desaturation, oxygen therapy may be needed. I will do ABG for treatment purpose to see if there is any respiratory failure. And if present, then oxygen may be needed. And I will also do echocardiography and color Doppler to see if there is pulmonary hypertension.
Okay, why you will not do CT with contrast? Why you will do HRCT?
Because sir, I want to see the lung parenchyma, and for the parenchymal lesion, HRCT is the most appropriate test.
If you give contrast, what will happen?
With contrast, the HRCT will be scan will not be good visualization will not be found.
Okay, how are you going to manage this case? Treatment.
The management, at first I will educate and counsel the patient about the disease and its course and prognosis, and also about the medications he will require and their side effects. And I will start corticosteroid therapy for the patient, and I will give non-steroidal anti-inflammatory medications to relieve his joint pains, present joint pain. And I will give immunosuppressive therapy, that mycophenolate mofetil may be given. And I will also give influenza and pneumococcal vaccination and COVID-19 vaccination. And also I will send the patient to pulmonary rehabilitation, and I will assess his hand function. If needed, I will send the patient to physiotherapy of the hands and legs too.
How will you follow up this case?
For follow-up, I will assess the patient clinically with history and clinical examination and some investigation. During history, I will ask if the symptom is improving or it is getting worse further. And on examination, I will see the oxygen saturation level and compare it with the previous one. And also the 6-minute walk test I will do. And investigation, I will do spirometry, and I will see that if there is any deterioration in the FVC level, and that will require further attention.
Is there any role of antifibrotics in RA-ILD?
Right now, nintedanib is FDA approved right now for systemic sclerosis associated ILD. But if RA-ILD, there is progressive fibrosis, we can add nintedanib, but it has to be progressive fibrosis.
Okay, what will be the prognosis of this case? Mute হয়ে গেছে, unmute কর, হ্যাঁ। Mute হয়ে গেছে।
Correct.
হ্যাঁ, শোনা যাচ্ছে, বলো।
I will, so can you hear me, sir?
Yeah, what will be the prognosis?
Sir, prognosis of this patient is poor. When rheumatoid arthritis patient develops ILD, the prognosis is poor. But if the prognosis is better than IPF, prognosis is better than IPF, and if it is UIP pattern, the prognosis is worse than if it is NSIP pattern.
Okay, thank you very much. আমাদের আবুল কালাম আজাদ স্যার আসছেন, স্যার একটু যদি কমেন্ট করেন সবার জন্য ভালো হয়।
Thank you very much, Professor Mohiuddin and his team, Professor Amin, Dr. Sharmin. আমি অত্যন্ত মুগ্ধ হয়ে প্রেজেন্টেশনটা দেখছিলাম, শুনছিলাম, শিখছিলাম। এত অসাধারণ একটা ক্লাস, কম্প্যাক্ট, এবং যে সমস্ত প্রেজেন্টেশনগুলো নেওয়া হয়েছে, যেগুলো আমরা এখানে কোশ্চেন আনসার হলো, যে কমেন্টগুলো হলো, আমি মনে করি আমাদের আজকে যারা জয়েন করেছে এবং এই যে সবার জন্য রেসপিরেটরি সিস্টেমকে বোঝার জন্য এবং একটু আনইউজুয়াল প্রেজেন্টেশনে সেগুলোকে নিজেরা চর্চা করার জন্য অসাধারণ একটি ক্লাস হয়েছে। এবং আমি এই জন্য আমার আন্তরিক অভিনন্দন, ধন্যবাদ জানাই আমার অত্যন্ত আদরের ও সম্মানের ভাই প্রফেসর মহিউদ্দিন, যে অসাধারণ বাগ্মিতায় এই ক্লাসটি এত চমৎকার পরিচালনা করলেন। এবং আমি মনে করি যে এইরকম আমাদের অত্যন্ত কর্মনিষ্ঠ শিক্ষকরা এবং যারা ছাত্রদের ভালোবাসেন, তারা এই কর্মকাণ্ডের মাধ্যমে আগামী দিনের সঠিক চিকিৎসক তৈরি করার জন্য তারা গুরুত্বপূর্ণ অবদান রাখছেন। এই জন্য আমি আমার কৃতজ্ঞতা জানাই, ধন্যবাদ জানাই। এবং আমার যারা আজকে জুনিয়ররা তৈরি হচ্ছে আগামী দিনের জন্য, আগামী দিনের বাংলাদেশকে আরো ভালোভাবে সেবা করতে পারবে। এবং এই আজকের ক্লাসের পরে রেসপিরেটরি ডিজিজের ব্যাপারে তাদের একটা বলিষ্ঠ অবস্থান তৈরি হবে এবং তারা সেইভাবে আল্লাহর রহমতে ইনশাল্লাহ মানুষকে চিকিৎসা করতে পারবে। ডাক্তার আমিনুল চমৎকার এখানে অ্যাঙ্কর করেছেন এবং আমাদের এখানে শারমিনকে দেখলাম এবং আমাদের যারা আমাদের নওশাবানুর এই অনুষ্ঠানটা মডারেট করছে। এবং আমরা সবাই মিলে আশা করি ইনশাল্লাহ এই পদ্ধতির মাধ্যমে আগামীতেও আমরা এই গ্রুপের ক্লাস আরো চাই এবং তারা আমাদেরকে রেসপিরেটরি সিস্টেমকে আরো পড়াবেন। এই আশাবাদ ব্যক্ত রেখে সবার সুস্থতা কামনা করি, সবার সমৃদ্ধি কামনা করে আমি আমার বক্তব্য শেষ করছি। ধন্যবাদ। আসসালামু আলাইকুম।
স্যার আপনাকে ধন্যবাদ। আমি আর 2 মিনিট কথা বলে একটু ওভারঅল করি স্যার, আপনার অনুমতি চাই স্যার। ধন্যবাদ সবাইকে।
এখানে একটু বলি স্যার, আমার চ্যাট বক্সে কিন্তু কোশ্চেন আছে কিছু স্যার।
আচ্ছা, কোশ্চেনের অ্যানসার দিব আমরা, আমি ওভারঅল একটু ডিসকাশন করছি। ধন্যবাদ সবাইকে এতক্ষণ আমাদের সঙ্গে থাকার জন্য। আমি 221 জন পর্যন্ত দেখেছি, এখন কমে যাচ্ছে, সবাই ব্যস্ত। তো লং কেস উই মাস্ট প্র্যাকটিস। আমরা তো এক্সামিনার, ওই পরীক্ষাতে লং কেস প্রেজেন্টেশন দেখে আমরা বুঝে ফেলি যে আপনি প্র্যাকটিস করেছেন কি করেছেন না। এবং লং কেসের জন্য বিসিপিএস এর শিডিউল টাইম হলো প্রেজেন্ট করার জন্য আপনি 6 মিনিট মাত্র টাইম পাবেন। 2 জন এক্সামিনার থাকবে, ফার্স্ট এক্সামিনার উইল ক্রস ইউ ফর 6 মিনিটস। এক্সামিনার দেওয়া অ্যাবান্ডেন্ট টাইম দেওয়া হবে না, যা ইচ্ছা তাই জিজ্ঞেস করে, 6 মিনিটের মধ্যে আপনাকে অ্যাসেস করবেন। নেক্সট এক্সামিনার উইল গেট 6 মিনিট টাইম, এই হলো 18 মিনিট। বাকি 2 মিনিট থাকে এক্সামিনাররা নিজেদের মধ্যে একটু ডিসকাস করার জন্য। এই হলো বিসিপিএস এর লং কেসেস টাইম। Same time frame is followed is BSMMU in phase 1, phase A এবং phase B examination. Unless you practice, 6 মিনিটে কোনো মতেই আপনি লং কেস শেষ করতে পারবেন না। আমাদের প্রথম শারমিন সুলতানা যেভাবে করেছে, যে হাইলাইটস গুলো বলেছে, আপনাকে কেস নিতে হবে পুরোটাই, কিন্তু হাইলাইটস গুলো বলতে হবে স্যারদের কাছে প্রেজেন্ট করার সময়। এটা দুইজনে মিলে প্র্যাকটিস করবেন, নাহলে 6 মিনিটে কিন্তু বলতে পারবেন না। আমি অনেক টিচারকে দেখেছি লং কেস আপনি জাস্ট জেনারেল এক্সামিনেশন বলার পরেই তার 6 মিনিট শেষ হয়ে গেছে, তখনই বলেছে যে ইউ হ্যাভ ফিনিশড ইউর টাইম, বাস উনি ওখানে আটকে দিয়েছে। তো ওখানে আটকে দিলে তো পরীক্ষা ওখানেই ডুবে গেল। সেই জন্য আপনাদেরকে প্র্যাকটিস করতে হবে। আমরা এই টাইম ফ্রেমটা মেনটেন করতে পারি নাই আমাদের ইয়ের কারণে, যেহেতু সামনাসামনি না, এগুলো দেখাই দিয়েছে স্ক্রিনে, টাইম ফ্রেম মেনটেন করা যায় না, এক্সামিনারও পারি নাই, এক্সামিনারও পারে নাই। দ্বিতীয় হলো যারা এখানে আমরা তো প্রায় 200 জনের মতো ছিলাম, সবাই কিন্তু এক্সামিনার ছিলাম, আর এক্সামিনার ছিল মাত্র 2 জন। এখন এক্সামিনারদের কাছে প্রশ্ন এই যে এক্সামিনাররা পাস করবে না ফেল করবে বলেন? হ্যাঁ এক্সামিনার, আচ্ছা ঠিক আছে। এখন আপনি ওভারঅল কমেন্ট করেন, আমার ইয়ে শেষ।
স্যার থ্যাংক ইউ সো মাচ স্যার, মানে আমি নিজেও আসলে অনেক কিছু শিখলাম আর কি আজকে, এবং খুবই ইন্টারেক্টিভ সেশন ছিল, তো খুবই ভালো লেগেছে। বিশেষ করে দুজন আপু, তারা তো মাশাআল্লাহ খুবই ভালো পারফর্ম করেছিল, বিশেষ করে ক্রসিং। স্যার আপনারা দুজন স্যার যে কোয়েশ্চেন গুলো করলেন, এবং অনেকগুলা মানে আসলে তো স্যার এইভাবেই কোয়েশ্চেন করে পরীক্ষার সময়, এবং এটা অবশ্যই ডেফিনেটলি খুবই হেল্পফুল হয়েছে স্যার, আমার নিজের জন্য এবং স্টুডেন্টদের জন্য ডেফিনেটলি হবে স্যার। স্যার আমি একটু কোয়েশ্চেন গুলো কি একটু বলবো স্যার? আমাকে চ্যাট বক্সে ডিরেক্ট মেসেজে কতগুলো কোয়েশ্চেন আসছে স্যার। একজন কোয়েশ্চেন করেছেন যে নন পালসেটাল জেভিপি কজ এন্ড ডিটেইল, এটা একটা কোশ্চেন করেছে। আরেকটা বলেছে যে
একটা কি করো তাহলে নন পালসেটাল ট্রিটমেন্ট ডক্টর শারমিন সুলতানা বলো এর কি কি কজ আছে। নন পালসেটাল নেক ভেনের কি কি কজ আছে ডক্টর শারমিন সুলতানা?
Yes, sir.
বলো।
Sir, non-pulsatile GBP usually the superior vena cava obstruction due to sometimes it may be due to lymphoma, some mediastinal mass can cause the compression from outside. In that case, we got the non-pulsatile GBP.
হ্যাঁ, আমি একটু অ্যাড করি শারমিন সুলতানের সাথে। আসলে সুপিরিয়র আমরা জেবিপি কেন দেখি? জেবিপিটা আসলে কি ডাইরেক্ট ভিজিবল পার্ট অফ রাইট হার্ট, তাই না? হার্ট তো আমরা দেখি না, সুপিরিয়র ভেনা কাভা তো দেখি না, কিন্তু এই জেবিপি জগুলার ভেইন সুপিরিয়র ভেনা কাভা হয়ে রাইট এট্রিয়ামে ওপেন হচ্ছে, সুপিরিয়র ভেনা কাভা রাইট এট্রিয়াম, আর উপরে আছে জেবিপি ইন্টারনাল জগুলার ভেইন। তো ডাইরেক্টলি আমরা হার্টের প্রেশারটা কিন্তু ইনডাইরেক্টলি এই জেবিপির মাধ্যমে মেজার করতে পারি। তো ইফ দিস এনগোর্জড জগুলার ভেইন ইজ সেকেন্ডারি টু রাইট হার্ট প্যাথোলজি, সেক্ষেত্রে আমরা পালসেটাইল পাবো, কারণ হার্ট তো আর নন পালসেটাইল থাকবে না, হার্ট ইজ অলওয়েজ পালসেটিং, তাই না, অলওয়েজ কন্ট্রাক্টিং। এবং আদার দেন দিস মে বি সুপিরিয়র ভেনা কাভা থ্রম্বোসিস, দিস মে বি ফিক্সড অবস্ট্রাকশন ফ্রম আউটসাইড, হ্যাঁ, that may be due to malignancy, that may be due to lymph node, or otherwise we will get non-pulsatile GBP. So if it is due to heart cause, that is pulsatile. If non-cardiac other causes including thrombosis and compression, these will be non-pulsatile.
Thank you sir for explanation, মানে এখন বুঝতে আসলে জিনিসটা অনেক সহজ হয়ে গেল আর কি। স্যার নেক্সট কোয়েশ্চেনটা যেটা আসছে আমাদের এখানে যে if DPLD association happens with traction bronchiectasis in CT scan, then what will be the clinical findings, fine or coarse freckles? DPLD with traction bronchiectasis.
আচ্ছা DPLD কার ছিল যে বলো শারমিন আফরোজ বলো।
Yes, in DPLD, there may be traction bronchiectasis may be present, and it is a find of DPLD, and we will find fine crepitation. Post crepitation we find in bronchiectasis, and traction bronchiectasis is different from the normal bronchiectasis in some ways. That is, here there is no inflammation or thickening of the bronchial wall. Here the pathology is in the parenchyma. Due to parenchymal pathology, the bronchus is distorted and pulled, and due to the torsion, the bronchus is pulled and dilated, but the bronchial wall is not thick. And this is the difference between other bronchiectasis and traction bronchiectasis. So in other bronchiectasis, the main pathology is in the bronchial wall. So for this difference, we find here in the fine crepitation. Thank you.
Thank you, doctor, for the explanation. My next question is what, how much is the percentage? How much clubbing is common in RA with ILD? Like he wants to know the percentage. Like RA ILD সাথে কি clubbing টা common বা কত percentage দিছে হয়?
Okay, so actually I don't know the exact percentage, but in case of connective tissue related ILD, the most common is the RA ILD, where we can find the clubbing, than the other connective tissue disease related ILD.
I can add some
sir.
points. Clubbing and cyanosis are the most striking finding, general examination finding in ILD as a whole, TPLD or ILD. But we should not refrain from diagnosing ILD that on the basis that the patient has no clubbing, no cyanosis. These are found only 30% cases, and especially at the advanced case. So we should not wait for respiratory failure to develop cyanosis. We should not wait to go to advanced stage of ILD to develop clubbing. So if it is found clubbing and cyanosis and bilateral nasal traps, this easily tells us that this is ILD. But if we do not get clubbing, if we do not get cyanosis, still we should stick to diagnosis to ILD if other features, say crepitations or HSCT features suggests. The final answer in one sentence, around 30%.
Thank you, sir. The next question is, as this was the case that was presented, it was DPLD due to RA, why have replaced methotrexate by methylphenidate mofetil?
Sharmin Hafiz বলেন।
In case of connective tissue disease related ILD, we usually use the corticosteroid and along with some immunosuppressive, and most commonly use the first line we use the mycophenolate mofetil. And as the patient is getting methotrexate, it may be added to the methotrexate, or I didn't say to stop the methotrexate.
Maybe he was asking like as the case was presented like that the ILD was due to RA, so এটা তো শিওর ছিল না যে methotrexate তো পাচ্ছিলেন পেশেন্টটা, সো methotrexate এর জন্য হয়েছে কি সেই জন্য কি রিপ্লেস করা হলো বা এই জন্য হয়তো কোশ্চেনটা করা
আমরা
হয়েছে।
হচ্ছে we can solve it clinically because in case of methotrexate related pneumonitis, it usually appears within the first 1 or 2 years, and in 50% of case patient develops methotrexate pneumonitis within 4 months of the starting of the treatment. So in this patient started treatment 6 years back, and patient developed pulmonary symptoms for last 7 months. So this can somewhat exclude the methotrexate pneumonitis or methotrexate induced fibrosis.
Thank you. The next question, the same doctor asked, like, is there any antifibrotic, parfenidone or nintedanib agent for any specific DPLD? I guess Apu has explained that before, but he asked like whether any antifibrotic specific for any.
Yes, right now it is recommended by FDA. FDA approved that in systemic sclerosis induced ILD we can use the nintedanib, and for other cases of ILD, if it is in the progressive form, we have to first see if it is the progressive. If progressive, then we can use nintedanib, and also parfenidone can be used, but right now nintedanib is FDA approved, mainly for systemic sclerosis.
So all ILD we should prescribe antifibrotic. In which variety it will be more effective? Like আমরা কি সব সময় ILD পেলেই antifibrotic এ যাব? এটা কোশ্চেনটা করেছে।
না, সেটা হচ্ছে যদি আমরা প্রোগ্রেসিভ ILD পাই, এটা প্রোগ্রেসিভ কিনা সেটা বোঝার জন্য আমাদেরকে FBC মনিটর করতে হবে। যদি আমরা দেখি যে FBC কুইকলি ডিটেরিওরেট করে যাচ্ছে এবং সেটা সেট মার্ক আছে কিছু যে 6 মান্থসে 10% বা এক্স্যাক্টলি এটা আমার ঠিক আসলে এখন মনে নেই, স্যার রাজু বলতে পারে। এরকম যদি থাকে, যদি প্রোগ্রেসিভ পাই আমরা, সেক্ষেত্রে আমরা অ্যান্টিফাইব্রোটিক দিতে পারি। আর সিস্টেমিক স্ক্লেরোসিস উইথ ILD এর ক্ষেত্রে নিনটেডানিবটা এখন FDA অ্যাপ্রুভড।
আরেকটা লাস্ট, এটা আসলে কমেন্ট বলা যায়, মানে না কোশ্চেন না, সেটা হচ্ছে এটা স্যারদের কাছে করা যায় লং কেস এক্সামিনেশন প্রেজেন্ট করার সময় 6 মিনিট করে হয়তো যে 4 মিনিট পরে মানে 2 মিনিটস লেফট এরকম কিছু বলা যাবে কিনা, এটা হলে স্টুডেন্টরা অ্যালার্ট হবে। এটা আসলে মনে হয় অ্যাডভাইস বা সাজেশন আর কি ফর টু বিসিপিএস আর কি একজন করেছে। So this is all about that I got question in my chat box. The presentation was fantastic. I must appreciate the effort of Dr. Sharmin Sultana, Dr. Sharmin Afroz আপু, আপনারা অনেক সুন্দর করে সাজিয়েছেন এন্ড মানে ক্রসিংটাও খুব ভালো হয়েছে। এন্ড অলসো আমিনুল ইসলাম স্যারকে আমি ধন্যবাদ জানাবো, স্যারও খুব সুন্দর করে ক্রসিংটা করেছেন এবং আমাদের ক্লাসে আজকে গেস্ট হিসেবে ছিলেন। থ্যাংক ইউ সো মাচ। আর মহিউদ্দিন স্যার, মানে ক্লাসটা আসলে মানে যেটা বারবারই বলা হচ্ছে যে লং কেস তো আসলে ভার্চুয়ালি নেওয়া একটু ডিফিকাল্ট, মানে আমরা তো সবসময় সামনাসামনি প্র্যাকটিস করা, তারপরে সবাইকে একসাথে করার জন্য আসলে এভাবে প্রেজেন্ট করা। তো সেই অনুযায়ী স্যার আপনি যেভাবে অ্যারেঞ্জ করেছেন, অর্গানাইজ করেছেন, আই মাস্ট অ্যাপ্রিশিয়েট দ্য এফোর্ট। থ্যাংক ইউ সো মাচ স্যার। স্যার আমার কোশ্চেনটা শেষ হয়েছে স্যার চ্যাট বক্সে, আপনি যদি স্যার কিছু বলে ক্লাস শেষ করেন স্যার।
আচ্ছা, স্যার বলার আগে জাস্ট আমি কোশ্চেন রিলেটেড একটু বলি, একটু যে যে রিলেটেড টু অ্যান্টিফাইব্রোটিক। আর অ্যান্টিফাইব্রোটিক এখনো আসলে ট্রায়াল চলছে, ডিফারেন্ট রিকমেন্ডেশন আসছে, হয়তো এটার ইউজটা আরো ওয়াইড হবে পরে, কিন্তু জাস্ট নাও আমরা আইপিএফ, ইডিওপ্যাথিক পালমোনারি ফাইব্রোসিস, শুধু এই ক্ষেত্রেই অ্যান্টিফাইব্রোটিকটা ইউজের রেস্ট্রিক্টেড আছি। হয়তো fibrotic variety of other ILD, say hypersensitive pneumonitis or systemic sclerosis, সেগুলো ওভারঅল ইন্ডিকেশন হয়ে যাবে। জাস্ট একটা কান্ট্রি রিকমেন্ড করছে, তারপর আরেকটা অ্যাসোসিয়েশন রিকমেন্ড করছে, দ্যাটস ওকে, কিন্তু ওভারঅল রিকমেন্ডেশন শুধুমাত্র স্টিল নাও আইপিএফ, ইডিওপ্যাথিক পালমোনারি ফাইব্রোসিস, সেক্ষেত্রে আমরা শুধুমাত্র অ্যান্টিফাইব্রোটিক দিব, কিন্তু উইথ টাইম সেটা বাড়বে, সেটা পরে হবে। আর ওভারঅল যদি জেনারেল লং কেস হিস্ট্রি নিয়ে বলি, আমি জাস্ট 2 মিনিট একটু বলি যে আমরা পেশেন্ট যে প্রবলেমগুলি নিয়ে আসবে সেগুলি থাকবে চিপ কমপ্লেনে, এবং চিপ কমপ্লেনের বাইরেও কিছু প্রবলেম থাকবে, সেগুলি ইলাবোরেশন অফ প্রেজেন্ট কমপ্লেনের মধ্যে আসবে। আর আরেকটা ব্যাপার যে হাইপারটেনশন, ডায়াবেটিস, এই কমন দুইটা কন্ডিশন আমরা কোথায় রাখবো, আর হাইপারটেনশন, ডায়াবেটিস, এজমা, হ্যাঁ, এটা আমরা ইলাবোরেশন অফ প্রেজেন্ট কমপ্লেনের মধ্যে রাখবো, কারণ পেশেন্ট হাইপারটেনশন, ডায়াবেটিস নিয়ে আমার কাছে আসবে না। আবার এই হাইপারটেনশন, ডায়াবেটিস কখনো পাস্ট হয়েও যায় না, এটা কখনো অতীত হয় না, সবসময় আমাদের সাথে থাকে বর্তমান হয়ে। সেই জন্য আমরা কি করবো, এটাকে ইলাবোরেশন অফ প্রেজেন্ট কমপ্লেনে রাখবো, নট ইন পাস্ট ইলনেস, নট ইন চিপ কমপ্লেন, সেটা। আর প্রতিটা লং কেসে আমি তাকে জিজ্ঞেস করব আপনার তার ডিজিজটা চিন্তা করে, এই ডিজিজের কি কি প্রবলেম হতে পারে সেটা আমরা জিজ্ঞেস করব। যেমন একটা রেসপিরেটরি ডিজিজ যদি হয়, তার কাফ, স্পুটাম, হিমোপ্টাইসিস, চেস্ট পেইন, হুইজ, ফিভার, তারপর কনস্টিটিউশনাল ফিচার থাকতে পারে। যদি এমন হয় যে এই সিমটমগুলির মধ্যে 2টা কি 3টা আছে, বাকিগুলি না থাকলেও ইম্পর্টেন্ট নেগেটিভ হিস্ট্রি পার্ট হিসেবে আমরা দিয়ে দেব। একটা পেশেন্ট যদি কার্ডিয়াক সিমটম নিয়ে আসে, হার্ট ফেলিউরের পেশেন্ট আসে, তার হয়তো চেস্ট পেইন নাই, তারপরও আমি চেস্ট পেইন ইম্পর্টেন্ট নেগেটিভ হিস্ট্রি হিসেবে দিব, কারণ সেটা সেই সিস্টেমের সিমটম। কারণ চেস্ট পেইন আমি যে কোনো ভাবেই হোক সেটা আমি এক্সপ্লেইন করতে পারবো। স্যার বলবো হার্ট ফেলিউরের পেশেন্ট চেস্ট পেইন কেন জিজ্ঞেস করছো, যে এটা এমআই এর জন্য হতে পারে, এইভাবে। সুতরাং ইম্পর্টেন্ট নেগেটিভ হিস্ট্রি আমি জিজ্ঞেস করব, আর নট অনলি দ্য সিমটমস অফ দ্যাট ডিজিজ, তার কি কারণে সেটা হলো। যেমন আইএলডির যদি কোনো কারণ থাকে, ফর এক্সাম্পল একটা পেশেন্ট ইন্টারস্টিশিয়াল লাং ডিজিজ নিয়ে আসলো, তার কোনো জয়েন্ট পেনের হিস্ট্রি নাই, আমি তাকে আমি মাথায় রাখবো যে এই আইএলডির কোনো কারণ আছে কিনা, অথবা অন্য যে কোনো ডিজিজ, যে কোনো কন্ডিশন, তার কোনো কারণ আছে কিনা, সে কজ রিলেটেড আমি তাকে কোশ্চেন করবো। তো যে জন্য আমরা জয়েন্ট পেনটা পেয়ে গেলাম, যে আপনার কোনো জয়েন্ট পেন আছে কিনা, কারণ আমরা জানি যে কানেকটিভ টিস্যু ডিজিজ থেকে আইএলডি হতে পারে। তারপর এই যে কন্ডিশনটা, তার কোনো কমপ্লিকেশন আছে কিনা, যেমন একটা ইন্টারস্টিশিয়াল লাং ডিজিজ, তারপর পালমোনারি হতে পারে, অথবা একটা রিউমেটয়েড আর্থ্রাইটিস, তার আদার কমপ্লিকেশনস হতে পারে, তার এক্সট্রা আর্টিকুলার ম্যানিফেস্টেশন থাকতে পারে, সেইগুলি কিন্তু আমাকে ধরে ধরে জিজ্ঞেস করতে হবে। যেমন একটা ব্রঙ্কিয়াল কার্সিনোমা, তার কমপ্লিকেশন হিসাবে তার মেটাস্টেসিস হতে পারে, তার এক্সট্রা কমপ্লিকেশন হোক বা ম্যানিফেস্টেশন হোক, বা এক্সট্রা পালমোনারি প্যারানিওপ্লাস্টিক ফিচার হতে পারে, সেগুলি আমরা সবকিছু এভাবে জিজ্ঞেস করব। তারপর কখনো কখনো এমন হয় যে তার এটা কজও না, কমপ্লিকেশনও না, ডিজিজও না, অ্যাসোসিয়েশন। ফর এক্সাম্পল এডিসনস ডিজিজ অথবা গ্রেভস ডিজিজ, তাই না? একটা গ্রেভস ডিজিজ ইন এনিওয়ে একটা অটোইমিউন ডিজিজ হিসেবে তার কিন্তু কিছু অ্যাসোসিয়েশন থাকতে পারে আদার অটোইমিউন ডিজিজ গুলি, যেমন তার এডিসনস থাকতে পারে, তার পার্নিশাস অ্যানিমিয়া থাকতে পারে, তার মাইস্থেনিয়া গ্রেভিস থাকতে পারে। তাহলে এই যে কজ, ডিজিজ, কমপ্লিকেশন, অ্যাসোসিয়েশন, এই সবগুলি পয়েন্ট যদি আমি লং কেসের পেশেন্টের কমপ্লেনের উপর ভিত্তি করে নিজের মধ্যে একটা চেকলিস্ট তৈরি করি, নিজে জিজ্ঞেস করি যে আমি কোনো পয়েন্ট বাদ দিচ্ছি কিনা, তাহলে দেখা যাবে যে আমার হিস্ট্রিটা তখন কমপ্লিট হয়ে যাবে। তো থ্যাংক ইউ।
ধন্যবাদ সবাইকে, পার্টিসিপেন্টদেরকে